Look at you. You studied really hard throughout your life. And now you are learning pathology. You might think that your life is going to be pink and rosy, but I'm here to tell you that the only pink that you're going to see is under the microscope. #Hematoxylin, #Eosin. Welcome to an introduction to the scientific study of human misery. Pathos means disease. Ology from logia or logos, the study of. It's the study of suffering, not in a poetic or mystic way, but in a realistic and objective manner, with patients that cough up blood in your face, abscesses that ooze pus on your hands, and cancers that you can touch with your hands and see with your eyes. Pathology is a subject that is dear to my heart. This is Medicosis Perfectionalis. Click the like button, click the subscribe button, and let's get started. This is my pathology playlist. It has more than 300 videos. In this video, we'll talk about the definition of pathology, the difference between biopsy and autopsy. We'll talk about the different types and approaches to biopsy. We'll talk about hematoxylin and eosin stain, which is why most things under the microscope appear either blue or pink. We'll talk about cell injury, especially hypoxia, cell death, apoptosis and necrosis, inflammation, both acute and chronic, amyloidosis, types of hypersensitivity reactions, and neoplasia. What is pathology? It's the scientific study of the nature of disease. It tries to know the definition of the disease, the causes of the disease. Some of these causes are genetic, some are environmental. Some are both interacting with one another. Some diseases are more common in the young, others are more common in the old. Some are more common in males, others are more common in females. Some are infectious, others are non-infectious, etc. Then pathology will try to study how the disease happened. What's the mechanism, which is called pathogenesis or pathophysiology or pathobiology. And then you take a sample of the tissue and look at it. How do you look at it? You look at it with your eyes first. This is gross examination. Gross here means big, not disgusting. And then you slice it, not dice it, and you look at it under the microscope. What's the difference between biopsy and autopsy? The word bio means living, as in biology, life. So if you're alive and I took a sample from your tissue, this is called biopsy. But after you turn into a vegetable, #the vegetative state, and after that, when it's over, a sample is called an autopsy. What is the most accurate test to diagnose acute sialadenitis? The answer is biopsy. How about chronic sialadenitis? Biopsy. How about benign tumors? Biopsy. Or autopsy, of course. How about malignant tumors or cancers? Biopsy again. There are many types of biopsy. You can take an incision, make an incision, that's incisional. You can remove the entire thing, excisional. We use these a lot in cases of skin cancer, such as melanoma, basal cell carcinoma, or squamous cell carcinoma. Out of these three types of skin cancer, which one is the most common? Let me know in the comments. There is brush biopsy, there is sponge biopsy, there is laser biopsy, there is fine needle aspiration. There are frozen sections. There is surgical pathology. There is forensic pathology. There is exfoliative cytology. Ology means the study of, cyto means cell. For example, suppose that the tissue of concern is the liver. So we try to take a sample from the liver. How do you take the sample? You can pierce through the patient's skin. Just boom into the liver, and this is called percutaneous, through the skin. Or, since the liver is connected to the hepatic veins, and the hepatic veins are connected to the inferior vena cava, and the inferior vena cava is connected to the right atrium of the heart, and the right atrium of the heart is connected to the superior vena cava, and the superior vena cava is connected to the jugular veins, there is transjugular biopsy, where you enter through the patient's neck, and then you descend until you are in the liver, and you take the sample that you want. You can also do so laparoscopically, a very small incision, or traditional surgery. Even the needles that you're going to use to take the sample or the biopsy have many types. There is core needle, which is big, fine needle, which is very fine and tiny. And then there are some techniques or technologies. There is an automatic core biopsy needle or automatic gun. There is a spring-loaded one. There is coaxial one with echogenic tip for ultrasound. Echogenic so that when you pierce the patient's skin with the needle, you can actually see your needle moving under ultrasound. This is called ultrasound guided biopsy. There is also cone biopsy, and we use cone biopsy for cervical cancer. To learn more about cervical cancer, please refer to my OBGYN playlist. I also have a separate playlist called Cancers or Oncology, where I talk about the different types of cancer. There is tissue biopsy versus liquid biopsy. Tissue biopsy is the actual sample of the actual tissue. Liquid biopsy is a blood test. Tissue biopsy is more invasive but more accurate. Liquid biopsy, less invasive but less accurate. If you want to establish the exact nature of the disease, go for tissue biopsy. If you want to follow up with some markers to see whether the cancer is progressing or regressing, whether the therapy is working or not, you can do liquid biopsy. So you took a sample from the patient's organ like a champ. What should you do? First, you comment on the sample with your naked eye, just by looking at it. No microscope yet. What should I comment on? Many aspects. Here are some of them. Which organ is this sample from? What is the size of the sample? Dimension-wise, you have to measure it. What's the shape of the sample? Color or colors, consistency, border, margin. What's the difference? One is seen with the eyes, the other is felt with the hands. And you need to palpate that sample to see whether it's hard, soft, firm, rubbery, or what. Then you're going to prepare the glass slide to look at it under the microscope. How do you prepare? First, you cut the sample. Then, fixation by formalin or formaldehyde. Then, dehydration by ethanol. Clearing by xylene. Embedding in paraffin. Incubation. And then you create a paraffin block. You slice that block with my kitchen knife. Shut up. With a microtome. What does micro means? Small or thin. Tome is to cut. Microtome means a device that gives you very thin slices, very thin cuts. And this is where the word anatomy comes from. Ana means up, tome means to cut. So anatomy literally means to cut you up. Metaphorically speaking, of course I will never cut you up because I love you. Pathologists never say that because they are a bunch of sociopaths. No pun intended. Then you stain, for example, using the Hematoxylin and Eosin stain. After this, you observe under the microscope. We have two types of microscope. There's light microscopy, which magnifies a lot, and electron microscopy, which magnifies even more. If you wish to see more pathology videos like this in the future, please drop a microscope emoji in the comments. We have many stains in pathology, the most famous of which is H&E stain or hematoxylin and eosin. Hematoxylin is basic and positively charged. Eosin is negatively charged. When something stains well with hematoxylin, we call it basophilic because philic means to love or to be attracted to the basic stain. But when something stains with eosin and appears pink, we call it eosinophilic or acidophilic. The nucleus of the cell is gonna appear blue, but the cytoplasm and the extracellular matrix will stain pink. By the way, the structures of the cell or outside the cells do not have to be acidic in order to be acidophilic or eosinophilic, and they do not have to be basic in order to appear blue or basophilic. This naming basophilic versus eosinophilic is not talking about the nature of the structure, acidic or basic, but it's talking about the stain. If you appear blue, it means that you're attracted to the basic hematoxylin. But if you are eosinophilic, if you appear pink, it means you're attracted to eosin. That's it. Fat-rich or hydrophobic, lipophilic but hydrophobic structures remain clear or white, meaning they are not stained with H or E, such as adipose tissue or fat cells, myelin, remember that sphingomyelin is a type of fat, and the membranes of Golgi apparatus, all of these appear clear. Next, we'll talk about cell injury and we'll focus on hypoxia. But before we do this, let me tell you how this pathology playlist is organized. So in my pathology playlist, you'll have many videos and they are organized in this order. First, we'll talk about introduction and cell injury, then inflammation and repair, then immunological diseases or immunopathology, then water, electrolytes, and acid-base disorders, then genetic and environmental conditions, then nutritional disorders. Next, neoplasia, benign tumors and malignant tumors, cardiac disorders, vascular disorders, red blood cell disorders, white blood cell disorders, hemostasis or disorders of coagulation, Respiratory system disorders, GI disorders or gastrointestinal and hepatobiliary and pancreatic diseases, kidney diseases, male reproductive system, female reproductive system, endocrine disorders, musculoskeletal disorders, skin disorders, and nervous system disorders. In this playlist, which has more than 300 videos. Do not confuse cell injury with cell death. So what's the difference? Cell injury is reversible, but cell death is irreversible. Can you give me an example? Sure. In the heart, the cell injury is called angina, but the cell death is called myocardial infarction. In the brain, cell injury is called transient ischemic attack, but cell death is called stroke. So therefore, TIA is reversible, but stroke is irreversible, and it will leave permanent sequelae. What causes my cell to be injured? Many insults can do so. Hypoxia or anoxia. Hypo means low, an means no, oxia is oxygen. Chemical injuries, physical injuries, free radical injury. This is not a political movement. Inflammatory issues, immunological causes, microbiological infections. Genetic causes, metabolic causes, nutritional deficiencies, whether we're talking vitamin deficiencies, mineral deficiencies, protein deficiency, or total energy malnutrition. Intracellular accumulation could be accumulation of iron, as in hemochromatosis, accumulation of copper, as in Wilson disease, and more. And finally, aging or senescence. For example, if you have watched my anatomy videos on the head and the neck, I have told you what happens to your mandible when you get older, and I've showed you some pictures. Hint, it's not good. Hypoxia or anoxia happen when there is less oxygen or no oxygen. Who's responsible for giving oxygen to the entire body? Well, you should thank your lungs for bringing oxygen into the body, and you should thank your heart for pumping, ejecting, and distributing that blood to the rest of the body. Chemical causes include polycyclic hydrocarbons, as in cigarettes, alcohol, medications such as acetaminophen, also known as paracetamol, heavy metal injury such as mercury poisoning, lead poisoning, arsenic poisoning, and more. To learn more about all these types of poisoning, I have a course on my website titled Toxicology, where I talked about all of these issues, including even cadmium poisoning. Physical injuries include radiation exposure, frostbites, burns, and skin wounds. Free radical injuries such as the famous superoxide, the hydrogen peroxide, and bleach, or hypochlorous acid for the chemistry buffs out there. Acetaminophen, oh, same drug? Yeah, can also injure my liver by means of free radicals or reactive oxygen species. Acetaminophen creates a very ugly poison known as napki. Too much napki can destroy the thickest of livers. So acetaminophen can damage your liver, whereas ibuprofen can ruin your kidneys. Inflammations can cause injury, such as cellulitis, necrotizing fasciitis. I've talked about many autoimmune conditions in my rheumatology playlist. Microbiological, whether bacterial infections, viral infections, fungal infections, or parasitic infections, whether they're caused by protozoa or helminths. Genetic or metabolic diseases such as phenylketonuria and diabetes mellitus. Nutritional deficiencies. I could be missing proteins, as in kwashiorkor. I could be missing carbs, I could be missing lipids, vitamins, or minerals, or I could be missing everything, as in marasmus. Intracellular accumulations. We have endogenous and exogenous accumulations. Endogenous accumulations include triglycerides and bilirubin. Exogenous accumulations include lead and anthracosis. Aging causes many changes. One of them is decreased cell replication. Another one is poor metabolism. Another is hearing loss. Another is vision loss and cataracts. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. Never ever forget that acetaminophen can ruin your liver by means of napki. Napki is an acronym which stands for a very long chemical word that will make you hate yourself. Napki depletes glutathione. Now your liver is unable to protect itself from free radical injury because glutathione is a free radical scavenger. To learn more about glutathione's mechanisms, please watch my video titled G6PD, where I talked about the role of glutathione. What is the antidote to acetaminophen? Well, if acetaminophen is going to deplete my glutathione, then the antidote has to be something that replenishes the glutathione. Yeah, it makes sense. What is that something that will replenish the glutathione? This is N-acetylcysteine, also known as NAC. Acetaminophen, what's the problem? NAPKI. What is the solution? NAC. But I'm here to talk more about hypoxia, which is a famous mechanism of cell injury. There is less oxygen for my tissues. Hypoxia can definitely lead to cell injury, and if it's prolonged, it can cause cell death. For example, if your brain was deprived of oxygen for, let's say, 2 minutes, then this is cell injury for your brain. But let's say that your brain was deprived of oxygen for 60 minutes. Well, you are toast. What causes hypoxia or low oxygen? We have 3 main categories. There is ischemia, there is hypoxemia, and there are hemoglobin abnormalities. Let's break the word ischemia down. What does the word emia mean? Emia means blood. And what about isch? Isch means little. Oh, lack of blood. All right. How about hypoxemia? Hypo means low. Oxy means oxygen, and emia means blood. So hypoxemia means less oxygen in the blood, particularly the P small aO2, which is the partial pressure of arterial oxygen. Definitions: hypoxia, low oxygen, inadequate tissue oxygenation. Anoxia, an means no, so there is no tissue oxygenation. If I am suffering from anoxia, then this is probably due to cardiac arrest or respiratory failure, because the lungs provide you with oxygen and the heart distributes that oxygen. Okay, I have hypoxia. Who cares? Well, hypoxia is a big deal because decreased tissue oxygenation will negatively impact the electron transport chain, #oxidative phosphorylation, and when your oxidative phosphorylation is gone, your ATP synthesis is gone, and without energy, you are toast. Causes of hypoxia again: ischemia, hypoxemia, and hemoglobin abnormalities. The types of hypoxia, which is a slightly different classification, is hypoperfusion hypoxia, also known as stagnant hypoxia, hypoxic hypoxia, better known as hypoxemic hypoxia, anemic hypoxia, and histiotoxic hypoxia. Hypoperfusion hypoxia is the same as ischemia. Hypoxic or hypoxemic hypoxia is the same as hypoxemia. Anemia and hemoglobin toxins are hemoglobin abnormalities. Let's start with ischemia. What causes ischemia? Well, it could be caused by a thrombus, which is a clot in the vessel, or it could be caused by an embolus, which is a clot that has formed somewhere else and then dislodged and then went to another artery, blocked that other artery. And of course, smoking and atherosclerosis are big risk factors. But it does not have to be a clot. What if I have congestive heart failure? Oh, congestive heart failure means my heart cannot pump, assuming that it was a systolic failure. And if my heart cannot pump, then my heart cannot supply my tissue with oxygen or blood. So therefore, I get tissue hypoxia from ischemia. And it does not have to be heart failure. It could be simply severe hypotension. My blood pressure is so low, there is no pressure in the vessels, so I cannot perfuse the tissues well enough. So they suffer from hypoxia. Next is hypoxemia. What is hypoxemia? It means decreased partial pressure of arterial oxygen, which is the free dissolved oxygen in your artery. Not to be confused with the oxygen on the hemoglobin, which is a different issue. The oxygen that's in the hemoglobin is called SaO2. S stands for saturation, A for arterial, O2 for oxygen, sometimes referred to as SpO2. S is saturation, P is pressure of oxygen. Let me show you different scenarios of ischemia. If there is ischemia, there will be hypoperfusion to the tissue. Hypoperfusion to your heart can cause cell injury, known as angina, or cell death, known as myocardial infarction. There are 2 types of myocardial infarction. There is the non-STEMI and there is the STEMI. No ST elevation myocardial infarction and ST elevation myocardial infarction. Cell injury to the brain is called a transient ischemic attack. but cell death in the brain is called a stroke. Since the stroke is caused by ischemia, we call it ischemic stroke. Not to be confused with the other type of stroke, which is hemorrhagic stroke. To learn more about strokes, please refer to my neurology playlist. And to learn more about angina and myocardial infarction, please refer to my cardiology playlist. Hypoperfusion to my kidney will give me pre-renal azotemia, which is an acute renal failure or acute kidney injury. I talked about it in more detail in my nephrology playlist. Hypoperfusion to the lungs will cause lung infarction, but infarction in the lung is red infarction and not pale infarction. Why red? Because the lung has a dual or double blood supply, one from the pulmonary and one from the bronchial arteries. We know that the pulmonary arteries come from the pulmonary trunk, which comes from the right ventricle of the heart. But where did the bronchial arteries come from? Which artery did they come from? If you know the answer to this question, please comment below. Hypoperfusion to your small intestine is called mesenteric ischemia, but hypoperfusion to your large intestine or the colon is called ischemic colitis or colonic ischemia. Hypoperfusion to your arm or leg will give you acute limb ischemia with the famous 6 Ps, discussed in detail in my surgery playlist. Hypoperfusion to your digits will give you Raynaud's phenomena. Hypoperfusion to your liver, ischemic hepatitis. Hypoperfusion to your gallbladder and biliary tree, acalculous cholecystitis, which is cholecystitis without stones. Hypoperfusion to your doozy pituitary gland is Sheehan's postpartum necrosis. Severe systemic hypoperfusion all over your body is the definition of shock. And this is how you summarize all of pathology in one slide, something that your professor will never do. If you go to my pathology playlist here on YouTube, I have several videos on hypoxia, where I talked about ischemia, hypoxemia, and hemoglobin abnormalities in great detail. What are the organs that are most vulnerable to hypoxia? Think about it. The most active organs are the ones that are most dependent on oxygen for their metabolism, and therefore they are the most vulnerable in cases of hypoxia. If you deprive them of oxygen, they suffer the most because they are super active. They need the oxygen every moment. These super active organs include your neurons. All of them? No, the best of them. Type A fibers. These are thick and myelinated. If you want to know the difference between type A fibers, type B fibers, and type C fibers, and the difference between 1A and 1B and 1C and all of this lovely stuff, please refer to my physiology playlist. Another active organ is the kidney. All of it? No. The proximal convoluted tubule and the thick ascending limb of the loop of Henle. Next, the liver. Which part? Zone 3, which is around the central vein. It is most vulnerable to hypoxia because it's further away from the artery. Because if you remember the lobules or the hexagons of your liver, they look like this. And in the midst of the lobule, there is this central vein. But at the edges of the lobule, what do we have? We have the famous triad. Okay, what is the triad or the portal triad? Well, we have an artery, we have a vein, and we have a bile canaliculus. What's the artery? Well, this artery is a branch of the hepatic artery. How about the vein? It's a branch of the portal vein. And this bile canaliculus, this is what will become hepatic ducts later. The artery is here at the edge, but zone 3 is around the central vein, not the portal vein. Oh, so this part, which is zone 3 of the liver, is very far away from the artery, making it the most vulnerable to hypoxia. Next, the watershed areas of the brain, such as those areas between the anterior cerebral artery and the middle cerebral artery territory, and those areas between the MCA and the PCA, or between the ACA and the PCA. To learn more about the arterial supply of the brain, please refer to my neuroanatomy playlist. Next, the subendocardium of the left ventricle. Why? Because when the coronary arteries penetrate the wall of the heart, they penetrate the epicardium on the outside. So the endocardium is far away from the coronary arterial supply, making it the most vulnerable to hypoxia. Next, the splenic flexure of the colon and the rectosigmoid junction. Why? These are watershed areas in the colon. Can you name the different arteries that supply the area around the splenic flexure? Can you name the different arteries that supply the rectosigmoid junction? If you know the answer to these anatomy questions, please comment below. By the way, I have anatomy review videos on every subject in anatomy. I have anatomy of the head and neck, anatomy of the thorax, anatomy of the abdomen, anatomy of the pelvis and the perineum. I have upper extremities, lower extremities, neuroanatomy, and even embryology review videos in my anatomy playlist. Kidneys. Which parts of the kidneys are the most vulnerable to hypoxia? Again, the straight segment of the proximal convoluted tubule, that's number 1. And number 2 is the medullary segment of the thick ascending limb of the lobe of Henle. What does that mean in reality? Well, this is your nephron. You will remember that you have a Bowman's capsule, you have proximal convoluted tubule, you have lobe of Henle, you have distal convoluted tubule, and then you have collecting tubules, collecting ducts, minor calyces, major calyces, renal pelvis, ureter, and then urinary bladder. The proximal convoluted tubule has 2 pieces. Closer to the Bowman's capsule, it's very convoluted, so this is the convoluted part of the PCT. But later, it becomes straightened a little. So we call this the straight segment of the proximal convoluted tubule. This straight segment is the most vulnerable part to hypoxia in the entire kidney. The second is the thick ascending limb of the lobe of Henle. You will recall that the lobe of Henle has a descending limb, which is thin, and an ascending limb, which is thin and then thick. Which part is the most vulnerable to hypoxia? The thick ascending limb of the lobe of Henle. Can we be more specific? Are we talking about the cortical part or the medullary part? The answer is the medullary part. Why? Because this medullary segment is far away from the vessels, making it more vulnerable to hypoxia. See, pathology makes so much sense once you understand what the French toast you're talking about. After talking about cell injury, it's time to discuss cell death. Cell death in pathology comes in 2 varieties: apoptosis, also known as programmed cell death or cell suicide, and necrosis, which is an unprogrammed cell death, also known as cell homicide. When the cell recognizes that it is too old or too sick and it's time for it to go, the cell can take its own life, so to speak, by means of apoptosis. But when an outsider comes and destroys the cell, this is necrosis. This is one way cancer destroys your cells. To understand this really well, we need to go back to basics. Cell changes in pathology come in 2 shapes: cell adaptation and cell injury. Cell adaptations is always reversible. These are reversible insults for the most part. Cell injury could be reversible or could be irreversible. Cell adaptations include atrophy, hypertrophy, hyperplasia, metaplasia, dysplasia, and neoplasia. But be careful, neoplasia can be irreversible. Or it might go away on its own, or it might get treated. Cell injury could be reversible, as in hypoxia to your brain for a minute or so, or could be irreversible, such as anoxia to your brain for more than 5 minutes or so. This can lead to cell death. Cell death comes in 2 shapes: apoptosis and necrosis. Let's compare between apoptosis and necrosis. Programmed, unprogrammed cell death. Cell suicide versus cell homicide. Apoptosis could be physiological or pathological. Necrosis is always pathological, always evil. In apoptosis, the cell will shrink. In necrosis, the cell will swell. In apoptosis, the membrane of the cell will form blebs, known as apoptotic blebs, without significant inflammation. But in necrosis, there could be significant inflammation and the cell membrane disappears, vanishes. And then after the membrane vanishes, you know what else is going to vanish? The nucleus of the cell. In apoptosis, your chromatins of the chromosomes get condensed and fragmented, and then the nucleus will undergo pycnosis, karyorrhexis, karyolysis. Pycnosis means shrinking of the nucleus. Karyorrhexis, fragmentation of the nucleus. Karyolysis is dissolution of the nucleus. By the way, the word karyo from karyon means nucleus. If you ask the average student about pycnosis, karyorrhexis, karyolysis, many of them will say, oh, they only happen in apoptosis, not necrosis. That's just a bunch of nonsense. Look, if the cell is going to die, the nucleus is going to die. So pycnosis, karyorrhexis, karyolysis happen in both apoptosis and necrosis. By the way, I hope you recognize the word ptosis in the name. It's as if the cell is falling apart. The word necro means death. Osis means condition, so necrosis is a condition of death. In apoptosis, the cell organelles will aggregate, but in necrosis, they break down. Apoptosis does not have an inflammatory reaction, or it's very minimal, but necrosis has inflammation. How do I know that there was apoptosis here? Look for a marker known as DNA laddering. These are fragments of DNA made of multiples of 180 base pairs. So you might find 180 or a multiple of this like 360, 540, etc., etc., etc. Next, let's talk about inflammation. What are the two types of inflammation? There is acute inflammation and chronic inflammation. Who are the heroes of acute inflammation? Your neutrophils, which are polymorphonuclear cells. So sometimes we abbreviate them as PMNs. Polymorphonuclear cells. An old way of abbreviating polymorphonuclear cells was like this: polymorphonuclear leukocytes. But PMNs is way more common. Next, what are the heroes of chronic inflammation? These are the lymphocytes. And of course, if you are an immunology connoisseur, you would recall that lymphocytes are mononuclear cells. Please recall that neutrophils have granules, but lymphocytes do not have granules. So granular versus agranular. To learn more about these white blood cells, please refer to my hematology playlist. There are more than 2,400 videos on this channel. What are the cardinal signs of acute inflammation? Redness, hotness, swelling, pain, loss of function, rubor, color, tumor, dolor, functio-lassay. Keep in mind that the word rubor or rubra means red. You will see this many times in medicine, as in polycythemia rubra ver, where we have many cells. What kinds of cells? Red blood cells. Calor, calorie, heat. Remember that the definition of a calorie, lowercase c, is that its amount of heat that is needed to raise the temperature of 1 milliliters of water by 1 degree Celsius. Calorie is the amount of heat. Dolor means pain. You see this in tic douloureux, commonly known as trigeminal neuralgia, which is very painful. When I have acute inflammation, there are some markers that will increase during the inflammation. We call these positive acute phase reactants. The acute phase is the inflammation. These include C-reactive protein, many complement proteins, coagulation factors such as fibrinogen, alpha-2 microglobulin, which I discussed in detail in a separate video. You can find that in my labs playlist, ferritin, hepcidin, ceruloplasmin, haptoglobin, and alpha-1 antitrypsin. Since these markers or these reactants go up in cases of inflammation, we call them positive acute phase reactants. Contrast that with those reactants that decrease in cases of inflammation. We call these negative acute phase reactants. These include albumin, transferrin, and antithrombin, among others. Why is the body doing this? To save resources. I do not need albumin and transferrin and antithrombin in case of inflammation. So therefore, I'll make less of them so that I save more resources to use them to make other stuff. Some common lab tests that can tell you that you have inflammation include ESR, erythrocyte sedimentation rate, and CRP, which is the C-reactive protein. Both of them are elevated in cases of acute inflammation. Unfortunately, they can only tell you that you have inflammation, but they cannot tell you what type of inflammation or in which organ. Anytime you have acute inflammation, you can bet the rent money that your interleukin-1 and interleukin-6 are high. Corticosteroids inhibit interleukin-1, among others. And that's why corticosteroids are what? Anti-inflammatory. Pharmacology makes so much sense once you understand what the French toast you're talking about. ESR and CRP can differentiate between osteoarthritis, where there is no systemic inflammation, and rheumatoid arthritis, where there is systemic inflammation. In osteoarthritis, ESR and CRP are usually within normal limit, but in rheumatoid arthritis, ESR and CRP are high because these are acute phase reactants and rheumatoid is inflammation. Acute inflammation, what's going on? Well, let's say, for example, that you have a bacterial infection. Where do you think the bacteria are? The bacteria are here, outside the vessel for the most part. They are in the interstitial fluid. Alright, who's gonna fight these bacteria? It's acute inflammation, so the heroes are the neutrophils. These neutrophils live in the blood, so therefore they have to exit the blood and be recruited towards the interstitial fluid to destroy these bacteria. What are the name of the chemicals that attract the neutrophils from the vessels to the interstitial fluid? These are the neutrophilic chemotactic agents, and they show up on every pathology exam. You need to know all of them. There is interleukin 1, leukotriene B4. 4 plus 1 is 5, so C5a. 4 minus 1 is 3, plus 5 is 8. That's interleukin 8. 4 plus 5 plus 8 is 17, because Th17 secretes interleukin 17. Interleukin 17 is a neutrophilic chemotactic agent or a recruiter of neutrophils. And don't forget the TNF-alpha. And that's the story of acute inflammation with redness, hotness, swelling, pain, loss of function. Why redness? Vasodilation. The vessel dilates and the neutrophils will leave the vessel to go to the interstitial fluid. Hotness. Why? Vasodilation. Swelling. Oh, why is this? Because the vessels are becoming more leaky. There is increased vascular permeability. And fluid will leave those vessels and go outside. And this fluid is an exudate. Why? Because it's rich in proteins and rich in cells, such as the neutrophils. Pain. Why? Because of bradykinin, because of prostaglandin E2, and because of histamine. And as Dr. Pathoma used to say, prostaglandin E is for fever and pain. Acute versus chronic, neutrophils versus lymphocytes, polymorphonuclear cells versus mononuclear cells. What's the outcome of acute inflammation? It could resolve, it could progress and become chronic, or it can make an abscess. An abscess is a collection of pus. The pus cells are the same as the neutrophils. Voila. Chronic inflammation outcome could leave a scar called fibrosis, could cause a disability, and is associated with amyloidosis. Amyloidosis is the next topic. I have a special video titled Amyloidosis Types, which you can find in this pathology playlist. This is what I want you to keep in mind forever. There are two main types of amyloidosis. There is primary amyloidosis and there is secondary amyloidosis. Primary amyloidosis is associated with AL proteins. These are the amyloid light chains, whereas secondary amyloidosis is associated with SAA, or simply AA protein, which stand for serum amyloid A proteins. Primary amyloidosis is associated with a cancer known as multiple myeloma. This is cancer of plasma cells, and plasma cells secrete antibodies, and antibodies have the light chains that we're talking about. Secondary amyloidosis, however, can happen with any chronic inflammation. We just said 2 minutes ago that one of the outcomes of chronic inflammation is amyloidosis. So there you go. What type of amyloidosis is associated with chronic inflammation? The answer is secondary amyloidosis. So the patient could have chronic tuberculosis, or rheumatoid arthritis, or systemic lupus erythematosus, or Crohn's disease, or ulcerative colitis. What all of these people have in common is secondary amyloidosis. So primary amyloidosis, think multiple myeloma. Secondary amyloidosis, think any chronic inflammation. Primary amyloidosis, this is the AL protein, but secondary amyloidosis is the SAA protein. Amyloid material appear pink under the microscope, so these are eosinophilic. Next, why don't we talk about hypersensitivity reactions? How many hypersensitivity reactions are there? The answer is 4 only. So there's type 1, type 2, type 3, type 4. Unfortunately, some professors in some countries have taught their students that there are 5 types of hypersensitivity. I have no idea what these professors are smoking. What they call type 5 is actually a subtype of type 2, where the antibodies cause stimulation rather than inhibition. This is what some professors call type 5. But these professors are delusional. And we'll talk about delusion later in this pathology playlist. Let's talk about hypersensitivity. Think of hypersensitivity as a heightened state of allergy, like a super allergy. Types of hypersensitivity are 4. There's type 1, type 2, type 3, and guess what? Type 4. Type 1 is immediate hypersensitivity reaction. Type 2 is cytotoxic. Look at this. Type 2 is cytotoxic. Toxic to the cell. Because there are antigen antibodies hugging and kissing one another on the surface of the cell. Type 3 is all about serum immune complexes. What is this? What's an immune complex? Antigen-antibody reaction freely floating in the blood. But usually not just one antigen, but many antigens, hence the name complex. Then the last is type 4, which is delayed type hypersensitivity reaction. By the way, do you know why we classify them this way as type 1, type 2, type 3, type 4? It's all about the time frame. Type 1 is the fastest to happen, but type 4 is the most delayed. 2 and 3 are in between. Type 1 is the fastest, type 4 is the slowest, 2 and 3 are in between. Type 1 is immediate, think anaphylaxis. Think mast cell degranulation releasing histamine. Histamine will quickly cause vasodilation, which decreases your blood pressure, bronchoconstriction, which causes wheezing and cough, and it can lead to some skin changes because of the vasodilation. Type 2 is cytotoxic, antigens and antibodies binding together on the surface of the cell. Type 3 is immune complexes, several antigens, an antibody making a complex, and they are floating freely in the plasma. So type 3 is free because these antibodies are freely floating in the plasma until they hit something. They can hit the vessel wall, causing vasculitis. They can hit a joint, causing arthritis, or they can hit your kidneys, causing nephritis. Vasculitis, arthritis, nephritis. 3 disasters in type 3. Type 4 is the delayed. Do not talk about any antigens or antibodies, but you need to talk about T lymphocytes rather than B lymphocytes. Remember that these antibodies came from plasma cells and plasma cells came from B lymphocytes. So type 1, type 2, type 3, they are talking about B lymphocytes. But type 4 is T lymphocytes, not B. Let me give you some examples for each. Type 1, think anaphylaxis, think atopy, such as asthma, such as atopic dermatitis, known as eczema, atopic rhinitis, and any atopy that you can imagine. If a bee stings you, you can get anaphylaxis. This is type 1 hypersensitivity, which happens very quickly. People who carry epinephrine pens with them do so because they might suffer from anaphylaxis. Type 2, antigens and antibodies on the surface of the cell. Type 2 is cytotoxic. These antigens and antibodies are mostly inhibitory to the target cell. Such as in rheumatic fever, the target cell is in the heart. Such as anti-glomerular basement membrane antibody, the target cells are in the glomeruli of the kidney. Such as myasthenia gravis, where the target cell is the skeletal muscle. Pemphigus vulgaris, where the target cell is the skin. But in one case, this antigen-antibody reaction is stimulating the target organ, and this is Graves' disease, where the antigen-antibody reaction stimulates the TSH receptor of the thyroid gland. Now the thyroid gland will secrete more thyroid hormone and not less. This is what some professors call type 5 hypersensitivity reaction. But again, these professors are inebriated. Type 3, free. You have immune complexes freely floating in the plasma, causing serum sickness or Arthus reaction. Serum sickness is acute, but Arthus reaction is subacute. Serum sickness is diffuse all over the body, but Arthus reaction is local, such as after injection, at the injection site. Many medications and some vaccines do so. After I inject you with a needle, around the site of entry of the needle, you suffer a localized reaction known as Arthus reaction. Then these antigen and antibody complexes, their immune complexes, are going to hit the vessel, vasculitis, the joint, arthritis, or the kidney, nephritis. Type 4 hypersensitivity reaction, think tuberculosis, think histoplasmosis, blastomycosis, coccidioidomycosis, sarcoidosis, even foreign body granuloma, and more. This is delayed. It takes 2 to 3 days after the exposure to actually cause the type 4 hypersensitivity reaction. The heroes here are T lymphocytes, not B lymphocytes. To learn more about the different types of hypersensitivity, I have a specific video on the topic of hypersensitivity reactions, and you can find this video in this pathology playlist. But I want to talk briefly about the story of the granuloma formation in type 4 hypersensitivity reaction. I guarantee you, you will find an exam question in this area right here. So let's suppose that we're talking about the TB skin test. This is a skin test for tuberculosis. The doctor is going to inject tuberculin, which is a protein, it's a purified protein derivative, into the patient's skin. If the patient has seen tuberculosis before, a granuloma will happen and the skin of the patient will be indurated, and that's a positive test. But if the patient has never seen tuberculosis before, the granuloma will not form and no induration will take place. What is the mechanism? What is the pathogenesis of this purified protein derivative test to diagnose tuberculosis? This is how it works. Keep in mind this takes time because this is type 4 hypersensitivity reaction, so the doctor will usually ask the patient to come back after 3 days. And usually this is how it goes down. The patient is going to call the doctor after 3 days. Doctor, can you tell me about the result of my test? So the doctor will respond, sure, come to the clinic, come to the office, and I will tell you the results. No, doctor, you have to tell me the result on the phone. I don't have time for this nonsense. So the doctor gently replies, my dear patient, the result of the test is in your arm. I do not have the result. Your arm has it. Come to the hospital, get your gluteus maximus here, and I'll tell you what's up. If the skin of the patient has induration, this is a positive test. No induration, negative test. Of course, it's a little complicated than this, and a good physician will never talk about the patient's gluteus maximus, but I'm just trying to keep it simple. The tuberculin that you injected into the patient's skin is the antigen, so it will be processed by an antigen-presenting cell. In this case, the antigen-presenting cell is the macrophage. The macrophage, just like a good waiter, will present the antigen to the CD4 T lymphocyte. On a tray, the name of the tray is MHC, and since this is CD4, it will interact with MHC2. Remember that CD4 cells interact with MHC2, but CD8 cells interact with MHC1. To learn more about MHC, please refer to my immunology playlist. Then the CD4 cells, which are T lymphocytes, will mature and grow up, and they will stop being so naive once they have recognized the antigen. A sign of maturity is the secretion of interleukin-2. Now it activates the CD4. CD4 is active, it is mature, and it's ready to go. This macrophage will stimulate this CD4 by means of interleukin-12. Now the active CD4 will become a T helper 1 CD4 T lymphocyte. And the T lymphocyte will say thank you to the macrophage. Dear macrophage, you have helped me become active and become a helper when you secrete interleukin-12. So I will return the favor and will activate you, dear macrophage, this time by means of interferon gamma. This path right here shows up on every exam. It's the fact that the T helper 1 CD4 T lymphocyte secretes interferon gamma to activate the macrophage, and then if the organism is easy and simple and weak, the macrophage will eat it by phagocytosis. But if the organism is strong, such as tuberculosis, the macrophage cannot eat it, but it can at least surround it and imprison it inside the walls of the granuloma. After the granuloma is formed, what is going to maintain the granuloma? The answer is TNF-alpha. Here are the tubercle bacilli, or the Mycobacterium tuberculosis, in the midst of the future granuloma. This will be surrounded by the activated macrophages, thanks to the T helper cell secreting interferon gamma. These macrophages have many names. You can call them macrophages, you can call them histiocytes, you can call them epithelioid cells, or you can call them epithelioid histiocytes. Histio means tissue, cyte means cell, epithelioid means epithelium-like. And then these are the CD4 cells. Oh, the ones that helped the macrophage and the ones that the macrophage helped. Correct. And then some of these macrophages will fuse together. They will share one cytoplasm, but they will retain their respective nuclei. And this is a multinucleated Langerhans giant cell. Please do not confuse Langerhans with Langerhans. Langerhans are the multinucleated giant cells, but Langerhans cells are the cells of the pancreas, specifically the endocrine pancreas. You know, the cells that secrete insulin, glucagon, and somatostatin. What's the name of the pancreatic cells that secrete insulin? What's the name of the pancreatic cells that secrete glucagon? And what's the name of the pancreatic cells that secrete somatostatin? If you know the answers to these three questions, comment below. Here are the bacilli of tuberculosis, the Mycobacterium tuberculosis, surrounded by the macrophages and the multinucleated giant cells, surrounded by the CD4 T lymphocytes, and then surrounded by fibroblasts. Since these are lymphocytes, this is a chronic inflammation. If you have watched my microbiology playlist, you will recall that tuberculosis has high fat content. Hence, caseating necrosis, cheesy necrosis in the middle of the granuloma, and we call all of this a caseating granuloma. There are two main types of granuloma, such as caseating granuloma and non-caseating granuloma. Caseating granuloma, I only remember 4, and virtually anything else is non-caseating granuloma. This is how I keep it simple. The 4 organisms that cause caseating granuloma include tuberculosis, histoplasmosis, blastomycosis, and coccidioidomycosis. The word mycosis means fungal infection. The non-caseating granuloma is anything else, including the granuloma of sarcoidosis and Crohn's disease and chronic granulomatous disease and foreign body granulomas and Bartonella henselae, etc. Next, a final touch of neoplasia. What's the difference between neoplasia and cancer? Neoplasia could be benign or malignant, but the word cancer always means malignant tumors. What are tumors? Well, tumors are growths. Not every growth is bad. Growth could be normal, part of embryological development and making organs during embryogenesis. Injured tissue grows and repairs and heals and regenerates. Cancer is another growth that is evil. It can be fatal. Where should we put cancer? Cancer is here. Cancer is a neoplasia. Neoplasia is a type of cellular growth, but it's not the only type. We also have hypertrophy, hyperplasia, metaplasia, dysplasia, and more. Hypertrophy is increased cell size. Hyperplasia is increased number of cells. The opposite of hypertrophy is atrophy, decreased cell size. Metaplasia is the change of tissue from one type to another type within the same category. From one type of epithelium to another type of epithelium. Or from one type of connective tissue to one type of connective tissue. It has to be within the same category. Now here's a side question for you. Do you know of any diseases where we can change cells across categories? For example, epithelium is becoming connective or some other crazy thing like this? If you can answer this question, I'll be so proud of you. Let me know your answer in the comments. Dysplasia. Plasia means gross. Dys means defective. So this is defective growth that is usually precancerous, before cancer. Then we have neoplasia, which are tumors. Some tumors are benign. These do not metastasize. And some are malignant. These do metastasize. When I say the word adenoma, oma is a tumor. A tumor is anything that ends with oma except Oklahoma. So adenoma, adeno means gland, oma means a mass. So it's a mass of glands, all right? And this is benign. But if you want to change the name into the malignant equivalent, you say adenocarcinoma. Adeno is gland, oma is mass, carcin is cancer, as in carcinogen. Carcino, cancer. Genesis. So a carcinogen is something that causes genesis of cancer. Papilloma is benign. Papillary carcinoma is malignant. Lipoma, benign. Liposarcoma, malignant. How can we define neoplasias or tumors or any word that ends in oma? Abnormal mass of tissue whose growth exceeds and is uncoordinated with that of normal tissue, and it persists even after the cessation of the stimulus that caused the growth in the first place. Tumors or neoplasias or words that end in oma come in 2 varieties, benign and malignant. Benign never metastasize. Malignant can metastasize. Malignant is synonymous with cancer. And these have 2 types. Cancer that is made of epithelial tissue is carcinoma, but cancers that are made of connective tissue are sarcomas. Also, cancers of muscles are referred to as sarcomas as well. But we put the word myo before sarcoma, so myosarcoma is cancer of muscles. Carcinomas usually metastasize to lymph first, but sarcomas metastasize to blood first. Please do not confuse the word cancer with the word carcinoid. What does oid mean? Oid means like, so carcinoid is cancer-like. That's what the word means. In dermatology, there is an evil condition known as pemphigus vulgaris, and there is one that's less evil, pemphigoid. Pemphigus versus pemphigoid. Epithelium versus epithelioid. And now, for the first time, you know what the word android mean. Oh, Android, the operating system? Yeah, what does Andrew mean? The name Andrew means a man, and oid means like. So android literally means man-like, meaning human-like. That's why the logo of Android is a robot, like humans. According to legend, some feminists complained about this name Android because they did not like it. And that's why, this is some insider information, Google next month is announcing a new operating system. They will name it Gynecoid. Next, some explanations behind cancers. Genetic explanations include proto-oncogenes and tumor suppressor genes. Proto-oncogenes, think of these as the accelerator of the car to speed up cancer formation. But tumor suppressor genes are like the brakes to stop cancer progression or cancer formation. So therefore, if you want cancer to happen, you either slam on the accelerator by activating the proto-oncogene to oncogenes, or you destroy the brakes until they malfunction by removing the tumor suppressor genes. When the proto-oncogenes become oncogenes, we call this gain of function, the accelerator. But then when you lose the brakes, this is called loss of function. Proto-oncogenes require one hit because it's usually dominant mode of inheritance, but tumor suppressor genes have a recessive mode of inheritance, and that's why it requires a two-hit. This is the two-hit hypothesis. Examples of proto-oncogenes include SRC, RET, ALK, BCR-enable, BCL2, c-KIT, c-MYC, and more. The one that they ask about the most on exams is RET. Tumor suppressor genes that you need to know about, never ever forget the RB and the P53. And also the BRCA1 and 2. What does BRCA stand for? BR stands for breast, CA for cancer. So BRCA is breast cancer 1 and breast cancer 2 genes. These are oncogenes, these are tumor suppressor genes. Of course, this is not a comprehensive list. What books should you use if you're interested in pathology? If you are a beginner, I recommend one of these two books. There is Pathoma and there is Golion. Both of them are good. Pathoma is shorter and more concise. Golion is longer. But then for the pros, there is Robbins. Even Robbins has many books. One is for students and it's called Robbins Basic Pathology. The longer version of Robbins is called Robbins Pathologic Basis of Disease. They also have one for cases like questions and answers and another atlas for pathology. Robbins is so popular to the point that even senior pathologists call him daddy. There is also another one called Rubin's Pathology with a U instead of an O. If you don't like books and prefer videos, watch this pathology playlist, which has more than 300 pathology videos, and I'm just getting started. I'll keep adding more and more and more. There are many ways to study. The means of learning are abundant. It's the desire to learn that is scarce. These are the topics that we discussed today. Now go watch my entire pathology playlist. If you want to learn about myocardial infarction, the types of stroke, cardiac arrhythmias, ARDS, acute limb ischemia, drowning, all the toxidromes that you can imagine, download my emergency medicine high yields course at medicosisperfectionalis.com. It comes with videos, notes, and cases. To learn about trauma surgery, pediatric surgery, neurosurgery, cardiothoracic surgery, vascular surgery, orthopedic surgery, and more, download my surgery high yields course at medicosisperfectionalis.com. I also have a third course for obstetrics and gynecology. It's called OBGYN High Yields course, which will teach you about normal pregnancy and the complications of pregnancy, as well as many gynecological conditions, such as cancers of the vulva, vagina, cervix, uterus, ovaries, and more. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.